Welcome and good afternoon. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today, not only here but via the webcast, those of you that are listening in. As you know, this is our Smarter Health Seminar at the University of Waterloo, and we're exploring in this series the e-health strategies locally, provincially, and globally as well. Special welcome to our speaker, Dr. George Passett, Executive Lead for Public Health System Transformation at the Ministry of Health and Long-Term Care. A special thank you to our seminar series sponsors, Borden, Ladner, Gervais, McKesson, Healthcare Information Management and Communications Canada, Smart Systems for Health Agency, and RIM, who will be providing a BlackBerry as part of the draw at the end of this session. So don't go away. Before I start, just one announcement. The last seminar of this series will be held on Wednesday, June 21st. Dr. Bill Haber, family physician and senior partner, Lakeside Medical Clinic in Saskatoon, if I can get that out, will be our guest speaker. He'll be talking about the physician's office in the era of e-health. I've looked at the abstract. It's very interesting how he wrote it, so I'm sure you'll enjoy that seminar. As I indicated, the purpose of the e-health seminar series is to examine the Canadian and Ontario e-health strategies in detail. These seminars give us a chance to learn more about these strategies and to critically evaluate their progress. After Walkerton and SARS, I'm sure all of us are very interested in the role of public health, not only in Waterloo, but federally, provincially, at all levels. Dr. Passett was the medical officer of health and CEO for Simcoe County at that time. Is that correct? So he's very aware of the situation. Dr. Passett has an incredible career. He graduated from the Faculty of Medicine at the University of Toronto and did postgraduate work in the Division of Community Health. He holds a number of fellowships and is certified, board certified, and a fellow of the American College of Preventive Medicine. He's worked with the ministry, he's worked at public health at the ground level, and it's with great delight that we have him here today to talk about supporting public health renewal. George?
Thank you, Shirley. It's indeed a pleasure to be here, and I wanted to also echo my thanks and to extend my appreciation to the seminar sponsors. This seems like an excellent series, and hopefully this presentation will live up to the past series of presentations on e-health strategies here. I have the opportunity to speak to you a little bit about the public health system. And the public health system is often misunderstood and often confused to be many other things than what it truly is. And so the first part of my presentation is really a little bit of an education around the public health system. We often get confused with the publicly funded healthcare system. So you'll see media reports talking about, and the public health system should be doing something in this particular area. And what they're really talking about is that hospitals should be doing something in this particular area, or that physicians should be doing something in this particular area. And what I'm going to be talking to you about today is something that is a little bit more narrow. And some of you may have heard about it, and you certainly will have read about it, and you will most often have encountered it whenever there is a crisis, because you can be guaranteed that we're going to be on the front pages whenever there's a new outbreak, whenever there's an emerging disease, whenever there is a challenge that our community faces. Because public health is the organized activity of government to respond to challenges that impact us at a community level. It is very different than the services that are provided through hospitals, the services that are provided through physicians' offices, the services that are provided to maintain all other aspects of our healthcare system. So in order to understand the e-health component of what I'm going to describe to you at the latter half of my presentation, you really need to have a grounding in what the public health system is and how it is different from the traditional components of our healthcare system that you're more intimately familiar with. So the objectives for the next 45 minutes or so are to better understand the public health system in Ontario, to have a little bit of an understanding of some of the public health programs, particularly those that have been newsworthy over the last number of years, and to then understand the contribution that e-health can potentially make to the concept of public health transformation that I have a more direct responsibility for. So I'm going to start by trying to contrast the public health system with the other aspects of the healthcare system that you're more familiar with. This is a map of Ontario divided into south and north and divided into 36 blocks there that are public health agencies or public health units across the province. And the first thing that's immediately different is that if I were to ask a hospital CEO to describe who they provide services to, it would be a catchment area. It would be the persons who are provided service in that hospital who have been referred in by a set of community providers, and therefore the map for a hospital catchment area can be very irregular. It can be defined by the nature of the services that are provided in that hospital. It can be defined by the type of practitioners that that hospital has. It can be defined on whether it's a primary care, first-level hospital or a tertiary-level hospital in the province. It can be defined by many different things. The public health system, though, is geographically defined. The whole of the province is covered. Everyone in this province belongs within or lives within a particular public health unit. And that public health unit has to provide services. So we have, in fact, then, a geographic element to our service provision that needs to be understood. That creates immediate challenges, because whenever we're talking about the geography of Ontario, it doesn't take us long to realize that we're talking about tremendous differences in scale. The very fact that I had to split this map into two components and shrink the Northern Ontario component in order to get it to fit on the same slide, in order to allow the labels to be reasonably depicted, is an example of that. And what we have in Northern Ontario are health units that have a land area of responsibility that is larger than most of the countries in Europe, most of the eastern provinces in Canada. And we call these health units and we define a certain set of responsibilities for them in exactly the same way as we do for the City of Toronto or the region of Waterloo that we're in right now. And so we have these agencies called health units mandated to provide services, but mandated to provide these services on a reasonably equitable fashion across the whole of the province. That raises a variety of challenges because the geography, as I've indicated, is vastly different. And so in the City of Toronto, when you're providing your restaurant inspection services so that when we go out and eat at the restaurant this evening, we can be reasonably assured that standards of hygiene and public health inspection have been applied to that particular premises. It's a far different issue to do those restaurant inspections in the City of Toronto, where you might be able to do 6 of them in one block, than it is to do that in Northern Ontario, in Thunder Bay, and in all of the remote communities that may exist in those areas. So the concepts of geography are a defining element of a public health system because they influence all of the program responsibilities that follow. All of the challenges in terms of trying to provide service, as in most other areas of public service, become vastly different when you consider them in Northern Ontario versus Southern Ontario, rural Ontario versus urban Ontario. And those dimensions become important. It's also important to recognize that the size of the population that is served by a public health agency is vastly different. From 38,000 in the smallest health unit in Temiskaming, again a Northern Ontario health unit, up to 2.6 million in the City of Toronto. Those are profound differences in scale, and they translate to profound differences in the organizations that are providing services. And so the budgets for the health units based in 2004 varied from as little as $2.5 million in Temiskaming to $124 million in Toronto. And the number of staff that have been hired to provide public health services is as low as 38 and as high as 1800 or more. Now, why did I go into this introduction? It is because we often think of a public health unit and apply a uniform concept, imagining that the same type of intensity of service is applicable across the province. And that can't be the case. The health unit that has 38 staff doesn't have the technology experts on staff to be able to drive the type of technologically sophisticated solutions that an agency on the other end of the scale might have. The type of resources and capacities that you have in your smaller agencies will tend to be different than the resources that you have in your larger agencies. And all of this influences the abilities to utilize e-health solutions in a way to transform the system and to result in the provision of better public health services. So what are those services? Well, again, a contrast to the healthcare system. The Ministry of Health, or the provincial government, doesn't define the standards for treatment of a particular condition. So when it comes to treating a patient on dialysis, there are best practices and randomized control trials that define the types of services that should be provided to a patient with a certain set of factors. But the province does define the programs that have to be delivered by public health agencies. And they are defined in a variety of different areas. We are familiar with some of those areas, perhaps less familiar with other areas there. They're defined in a document called the Mandatory Health Programs and Services. And it's divided into 3 or 4 different areas. There are general standards, and those general standards include the ability of the need for a public health agency to respond to health hazards. So you've often heard of a public health report on a particular set of usually environmental conditions, a landfill that people are worried about. Is it or is it not a threat or a concern to the health of the people who live in that particular area? If you're following the issues related to waste incineration, there are, again, ideas about the possibilities of burning our waste, and the questions that are being raised are often put into the context of a public health question. Will this impact our health? And so that's, again, an example of a health hazard investigation. Many of you will have heard someone in your family, on your street, in your neighborhood, make an observation like, boy, there seems to be a lot of cases of cancer on this street. I wonder if, and then they fill in the blank with a particular exposure and say, I wonder if it's being caused by blank. And those types of cluster investigations, those types of assessments of whether or not your community, be it narrowly defined like your street or broadly defined like your whole region, whether they're experiencing a different health outcome, an undue occurrence of a certain set of factors, are all examples of the types of programs that public health undertake at a local level. The next category of programs is in the family health area. And it is a category that looks at the issues of child health, reproductive health, and defines the types of interventions that are necessary. So many of you will have heard perhaps of the Healthy Babies, Healthy Children program, where public health nurses and peer visitors, lay home visitors, provide direct home interventions for those families at risk in our communities in an effort to ensure that the children have an optimal chance at a healthy growth and development during their childhood. Other examples of programs in this area include efforts to ensure that babies are born with an optimal chance for healthy growth and development. And so there's a whole range of public health programs aimed at the maternal period to try to ensure that. At the bottom of that page, chronic disease and injury prevention are a whole set of programs that look at our modern epidemics. The modern epidemics being heart disease, cancer, being the risk factors that lead us to those chronic disease endpoints, like our use of tobacco, our nutrition, our lack of physical activity as primary examples there. And so you live in a region here in Waterloo where you've had the benefit of a smoke-free bylaw for several years now. And this week, over the coming week, you will see that type of legislation now introduced on a provincial level in order to ensure that there is an equal playing field across the province. Those are examples of public health programs trying to ensure that our communities are best positioned to ensure that we have the best possible chance at a healthy future. And the category I skipped over there was that of infectious disease, which is really the one that usually makes it to the front page of the newspapers. It's usually the one that talks about the outbreak that occurred in such and such a nursing home, or the threat of pandemic influenza, or the possible threat of avian influenza and what it might mean to Canadian society or to Canadian business or to a Canadian educational system. All of those issues become, first and foremost, public health issues. So, with that just as a background, what I thought I would try to do for you is give you several examples of public health in action, largely pictorial, to give you a sense of what happens behind the scenes. Because again, all of you can have a mental image of a hospital and the services provided in a hospital. You have that mental image of a physician's office. But when we take that down to a public health environment, it's sometimes more challenging. So the first is West Nile virus, something that's been in the news, continues to be in the news, and we're no doubt gearing up for another set of media reports related to West Nile virus. And this is a graphic that describes the chain of transmission related to a viral illness that is not primarily a human illness. It is primarily a bird illness. And so what we have is mosquitoes that become infected by feeding on infected birds, who transmit it to other birds who become infected, and it becomes a continuing cycle between mosquito and birds. But at certain points in the year, the mosquito populations change, or the bird populations change. And there is the opportunity to infect other incidental hosts. And those incidental hosts can be other animals, as in horses, or they can be humans. And what we experienced since 1999 is the introduction to North America of a new disease, at least to North America. Long seen before in Africa and parts of Asia and Europe, but had never before been described in North America. And so back in 1999, you would have possibly heard about the introduction of this virus in New York City, a cluster of cases of severe neurological illness occurring in New York, and the challenges that then manifested in trying to control that particular infection at that point in time. This again illustrates that not only was a public health system called upon to deal with an emerging disease at that point in time, but we were called upon to develop novel methods of learning about that particular condition. And so you will have seen advertisements for, either in the papers or heard them on radio, for reporting dead birds. Something that prior to 1999, 2000, no one would ever have considered, the concept of establishing a surveillance system, surveillance being one of the key public health functions, to document whether or not a particular area was at risk of West Nile virus. And so again, there were novel methods established to learn about the mosquito populations and learn about the bird populations that may have been susceptible to West Nile virus. This is a graphic that shows the migratory pathways of the birds as they migrate through their corridors in North America. And on the eastern seaboard, largely in red, that doesn't depict very well on the slide here, you have the Atlantic flyway. And the reason this is important and is distinguished from the Mississippi flyway and the Central flyway and the Pacific flyway is that when you looked at the surveillance reports that followed year after year after the introduction of this virus to North America, what you saw was, in year one, it was introduced in New York City. In year 2, all of the states and provinces that were on the Atlantic Flyway started to see evidence of West Nile virus activity. In year 3, you moved into the Mississippi Flyway. And in year 4, the Central, and in year 5, the Pacific. Because birds overwinter in the south. They mix there, and generally you saw a migration of a novel infection across North America in that particular context. And so you will recall from several years ago, there were a variety of different efforts that were put into place to try to deal with the challenges of detecting West Nile virus as it moved forward. So that's the life cycle of the mosquito, reminding us all that part of it is spent in water. And that was one of my staff, called upon to do something that had not been part of the public health work prior to that, which is to take samples from waters to determine the mosquito population and density in those waters to determine whether the community was potentially put at risk. And that is an example of the efforts to establish surveillance mechanisms for adult mosquitoes, where there was a trap baited with carbon dioxide and attracting mosquitoes that could then be quantified and speciated so as to determine whether the particular mosquitoes that would serve as potential vectors to humans were present in a particular area. And so we had these in people's backyards, spread across the county in an effort to establish the surveillance information that was necessary. So I share this with you because one of the critical functions of public health is surveillance. And surveillance isn't static, and surveillance can be enabled by technology, and surveillance has to respond to the modern conditions that might impact on our health as a community. Second area I wanted to go over with you is influenza. And this is a graphic that, again, illustrates the sensitivity that our society has, certainly following SARS, about the means by which infection is transmitted. Largely 4 or 5 years ago, it was very hard for me to give out the message that it was important for us to listen to what our mothers and grandmothers had always told us and wash our hands and not result in people smirking at that particular message. Post-SARS, I think people have a totally different sensitivity to the importance of effective infection control mechanisms or strategies in order to deal with those particular issues. So, this is a picture from 1997. And it was the introduction, it was the efforts at controlling what was then a new strain of influenza virus called the H5N1 virus, which was a particularly lethal strain for birds again, but which had been identified in Hong Kong to have infected a certain number of humans as well. And so the strategy of controlling that necessitated a strategy of assessing and, where necessary, depopulating the bird population, which in Hong Kong is an incredibly difficult thing to do. This is at the heart of our current concern about avian influenza. We are concerned about an avian form of influenza, which is a bird form of influenza, not because it currently has the direct capacity to impact on human health, but because it has the potential to exchange genetic material with the viruses, these very similar viruses that are human viruses, and to thereafter create a new virus that might be one that none of us has any prior exposure to, and to which all of us might be susceptible, and that would therefore result in something that would spread across the world, and that's what we call a pandemic. And so the challenge of understanding the global etiology of infections is also a public health challenge at a macro level. The reasons, for those of you who are immunized against influenza, the reason you are immunized on an annual basis isn't because the vaccine isn't good, it's because the virus changes so frequently. And you need to have an annual immunization in order to protect yourself against that new form of influenza. And that year-to-year change is something that we all understand, we all can accept, and that's called the drifting of the antigens that occur in influenza. But then influenza has the ability of really shifting radically, changing so dramatically that none of us have any prior exposure. And that's the concern that links us to the avian species and links us to surveillance activities that have to happen across the world and certainly have to be very vigilant in Asia, because you have so many people adjacent to so many different species of birds, adjacent to so many other species of mammals in a very confined area where viruses can exchange their genetic material more rapidly. So there is a huge issue with respect to understanding the implications of what might be happening around the world and could be on our doorstep based on the next transatlantic flight or trans-Pacific flight, and its possible impact to our communities. And so here I'm bridging to the fact that what is around the world can be a public health challenge to us very quickly. And that is very different than 1918. This is a copy of Time magazine that, again, goes back and looks at the efforts to try to identify to recover the genetic material of the influenza virus that caused the last major pandemic that was worldwide in scope and that had substantial mortality associated with it. And what our flu hunters are trying to do is to try to understand the things that have led to that particular circumstance taking place. But this was the outcome of that. This is a sign that would have been posted on a door from that point in time, and you'll see at the bottom it says, issued by the Provincial Board of Health. And it talks about the Spanish flu and the strategies that were necessary in order to prevent transmission of that particular infection from that particular site. And this is also what's leading efforts on a global basis that you're reading about in the newspapers to ensure we have an adequate supply of vaccine and can develop a vaccine for what might be a novel strain as quickly as possible, and also an adequate supply of the antivirals that are necessary in the event that, that a pandemic strain hits. And lastly, some historic pictures to again close the loop there to illustrate that in 1918 we had far different modes of travel, and that the pace of transmission of influenza from country to country was largely borne by the speed of ships and took months to move from one seaboard to the other seaboard across North America. And so what we're dealing with now are profoundly different challenges in terms of disease control that have to be understood, that really look at the issues of what types of tools are necessary in order to appropriately detect and manage these types of outbreaks. So, last example is one of safe water. For those of you who travel up north to the cottage using the Highway 400 and may stop at the Tims along the way, that is one of the Tims along the way. I want you to focus on the foreground of that picture. That's a well casing. So, we tend to take our water supply for granted. We tend to imagine that it's always there, always pure, always safe, and never needing a moment of concern. And I think Walkerton and the outbreak that followed that really perhaps challenged those types of assumptions. But this is an illustration that in non-urban parts of the province, we have water quality issues that have to be considered. We have water issues, in terms that one has to understand that the context of a water supply in rural Ontario is largely on the basis of individual wells. So I have, worked in the city of Toronto where there's one water system. I have also worked in the county of Simcoe where there are 40,000 individual wells serving households, and there's 400 municipal systems, some serving only 5 or 10 houses. Those all require intense data management when you consider all of the testing that's required in order to ensure water safety and quality in those particular environments. This is the water purification system in a rural school. So again, we sometimes take for granted that our public buildings, schools in particular, would have a water system that meets current standards, without thinking about what has to happen behind the scenes in order to ensure that those water systems can indeed provide potable water to those children. And this is an example, this is a picture of the type of technology that is used in the town of Collingwood and that was used on an emergency basis in the town of Walkerton. It's a membrane filtration unit, and all of those little spaghetti-like strands there are pieces of membranes that are best described as a straw. And so the raw water circulates on the outside of those straws and is then purified, filtered, by, in essence, sucking it into the lumen of that particular straw, for lack of a better description. And that's how the modern purification system for at least some communities works, and that is an example of that. One of my first tasks as a medical officer of health was to rescind the boil water advisory in the town of Collingwood following the cryptosporidium outbreak of 1996. On the basis of them having now installed a filtration system that would filter out that particular pathogen. So it again illustrates the importance of understanding the things that keep us healthy in our communities that we sometimes take for granted in the context of health issues. So, public health, e-health, how does it fit with all of this? Well, if you grasp the concepts that I've tried to portray to you, you've understood that public health as a system focuses on the community. It focuses on the community as a whole and tries to identify the conditions and factors that are necessary to keep us healthy in our respective settings. And one of the strategies that I'm partially responsible for is the Public Health e-Health Council, which is part of the Ontario e-Health environment, which is depicted here. That e-health environment is one which has an effort at establishing health informatics standards through a Health Informatics Standards Council. It has a variety of sectoral councils that look at issues specific to hospital environments, physician environments, the laboratory systems, the continuing care system, and, as I mentioned, the public health e-health councils. One of the seminar sponsors for today is the Smart Systems for Health Agency, which is evolving as the technology arm of the Ministry of Health in its effort to implement and deploy the types of products that are necessary to achieve some of these visions. In the public health strategy, we want to ensure that the public health system in Ontario has access to the types of information systems required to support the types of activities that I shared with you earlier. And that framework is comprised of a number of different things. Communication tools, specific public health applications, the development of standards and architecture, and the types of transitional supports that are necessary in order to enable that type of system. With the goal that the public health community work more efficiently to protect Ontario's communities and renew public health. So, what are the components? Well, what I'm going to try to describe to you are 4 elements of that public health e-health framework. They include communication tools, public health applications, the standards and the type of supports, within the context of something defined in as a public health community, which include the public health units as I've described them to you and shown them to you in the map, and the ministry functions at a public health division both within the Ministry of Health and the Ministry of Health Promotion in the province. But we can't do that alone, and that's really where some of the interactions have to cross into that broader health sector. the interactions that are necessary in order to address our health protection or health promotion mandate sometimes require us to interact very effectively with hospitals, physicians, long-term care facilities, retirement homes within the healthcare sector, and a whole range of other players and parties within other different sectors. Emergency response is only effectively done if you can interact effectively at a municipal level with your police, fire, ambulance, and other related partners. So there's a whole series of stakeholders that are engaged in this. In terms of communication, there are a variety of different activities currently under development, and several that are worth highlighting here are the public health communication portals. They include publichealthontario.ca, which I'll show you a screenshot of in just a second, ehealthontario.ca, the collaboration tools to establish communities of practice and try to break down some of the geography barriers that we face across the province, and mechanisms to get information out to those that need to receive it in the context of important health notices, and I'll try to describe those momentarily. When we get to applications, I'll try to describe some of the current efforts to develop public health applications that create more of a system for communicable disease control, for immunization information management, and for inspections. So the communication portals, as I've mentioned, are publichealthontario.ca, which is focused exclusively on, or specifically on, the public health community, and eHealth Ontario, which serves the broader health sector. So several years ago, there would have been no portal, no access to information, no website other than the Ministry of Health website that would have been available to broader stakeholders across the health system to access information about health issues. So think in the context of SARS and the environment following SARS, where information was rapidly changing, needed to be conveyed to a whole range of healthcare providers across the province, and very limited mechanisms for accomplishing that in the midst of a crisis. And these are strategies that are largely designed to try to address those particular issues. It shows on the timeline along the bottom some of the activities that have taken place in an effort to establish the portals, portals largely being a website interface with a whole range of inherent or built-in applications within those particular sites. And so there has been the introduction of drug viewers across the province at emergency departments, so that there is the ability to review, based on a common database, the Ontario Drug Benefit Database, the particular drugs that individuals who may be accessing that particular program may have received in the past. There was in December the initial efforts to test the important health notices, which I'll describe subsequently, efforts to introduce a collaboration service, and ongoing efforts to build the type of web applications that are described on this slide. This is a screenshot of the publichealthontario.ca site. And so if you can imagine some of the challenges that the public health system has on the basis of the map that I showed you at the start, you'll understand that really it is a very decentralized workforce. It's not much different than a multinational corporation that has its workforce spread across many different offices in many different cities or countries. And the challenges you face there are, how do you ensure that you can effectively collect information and provide information to that distributed workforce? And so this is an example of a portal that is largely being developed to address the needs of that decentralized public health workforce, to provide information on the types of research and evaluation activities that are underway in the public health system, to address the major learning needs that are present in order to ensure a professional workforce can engage in continuous professional development, to serve as a home for all of the projects and committees that are necessary to further public health action, to provide information about public health units, and again, the public health application issues. Important health notices are depicted on this part of the screen. And I want to walk you back to SARS when it became readily apparent that there was a great challenge in communicating urgent information to all of the doctors and nurses, all of the healthcare providers in long-term care, all of the other people who needed to know about what the current situation was and what the current recommendations were. It was a very challenging system, or a very challenging process to try to ensure that that type of information could be conveyed effectively to those particular communities. And the concept of mechanisms to communicate that effectively were born really in the heart of that particular outbreak. It was challenging because email lists didn't exist. The mechanisms to send large numbers of emails in a very short time frame across Ontario largely didn't exist. There were challenges in the abilities to ensure that that information that was needed in terms of the immediate protocols that were necessary to protect patients or to protect the healthcare providers could be implemented in that facility and that facility. Those challenges those challenges were difficult to address in that particular context. And so the concept of mechanisms that allowed for the rapid, timely deployment of important health notices to a broad audience were largely born in the SARS outbreak and have been used rather extensively since that point in time. So the issue here is, how does that chief of staff in the local hospital learn about something that's happening and the major recommendations that are necessary to control that threat in that particular hospital environment? You have to establish mechanisms in order to be able to do that. There are different mechanisms that are used in different jurisdictions. And in this jurisdiction, in Ontario, the portal conceptual architecture relies on a publication facility that in future will allow for multiple modalities of information transmission. That includes email, text-to-voice, fax, and messaging components. Right now, the email has been activated, and so we have the capacity to now broadcast email in a manner which did not exist previously. The issues of collaboration are another example of a public health activity that underlie many different aspects of public health programs. And so you have, again, the challenges of getting people working in different parts of the province, working effectively on a collaborative basis towards a certain endpoint. And so the portal technology enables that type of group process, that type of collaborative work to be undertaken using shared spaces and a whole range of technology tools that I'm certainly not the expert on. But what that is doing is largely breaking down some of the distance challenges that we have seen previously. We are now able to bring people together on a common project from varied areas, largely aimed at achieving a common endpoint without needing to bring them all into the same space and time. The publication facility that I mentioned has now 34,000 recipients, and so over and above those 34,000 recipients across the province, there are an additional 11,000 recipients who are defined largely on the basis of the roles that exist within facilities. This is one of the major challenges when you design a communication system for urgent communication that has to really broadcast this stuff very quickly. How do you ensure that the chief of staff in a particular hospital, the vice president of nursing, the person who's responsible for infection control all receive that message when the people are constantly changing? it's important that we acknowledge that we are dealing with a moving target at all times in an effort to establish any type of communication modality related to that. And so one of the responses to that has been the development of role-based mechanisms, where it's not the person who receives the email, but it's the person who fulfills a particular role in a particular venue who then receives that specific system. In terms of performance, I can only tell you that the ability to send 34,000 faxes and emails in the span of 4 hours is a remarkable improvement to that which we experienced during the midst of SARS. I can only tell you that it used to take countless hours to distribute on a broadcast basis those types of urgent health notices at the time. And they couldn't be done on Wednesday afternoon because they would bring the total provincial government system down to a crashing stop. So those are some of the challenges that have been overcome in an effort to establish a publication facility. Are we done? Not by a long shot. I want to share with you that because of my role at the provincial level, I have also been registered with the Michigan Health Alert Network. And one day I was in a meeting in Victoria and received a cell phone message. And it was a digitized message, and it said, the Commissioner of Health for the state of Michigan has just issued an important health notice. Please access it at this particular site. And that is an example of the mechanisms that are now being considered and implemented across many jurisdictions in an effort to ensure that people have the ability of specifying the mode that they wish to be contacted in. Do you wish to be contacted on your cell phone? Do you wish to be contacted by email? Do you wish to be contacted at home or by fax or by pager? And the ability to customize that so that we can get a message to a person in a way that deals with their particular style of practice. And that is an example of the types of things that are necessary as you consider the issues of emergency response and preparedness and ensuring that we can establish those types of communication channels to those that need to know on a timely basis. On the issue of public health applications, one of the challenges during SARS was the challenge of documentation by Post-it note. Many of you will have heard about this, but you had the cases that were thought to have been exposed to or to actually be documented to have the condition of SARS, and you had information that was being collected around them. There was no information system that, to which that information could be applied. Each health unit, because it's an independent corporation, had its own mechanisms of collecting that information. So when a particular patient worked in, let's say, worked in downtown Toronto, however, lived outside of Toronto in a different area, and may have seen a doctor in yet a third area, you had no means of integrating the information that may have been collected from the workplace, from the home-based investigation, and from the physician's office. That mechanism, the mechanism that was used at that point in time, was largely paper-based filing with a lot of sticky notes that identified the types of information that needed to be followed up on. Clearly not a mechanism that is sustainable in broader context. There were a very limited number of cases of SARS. And, again, that context could not have been scaled to a much larger outbreak. Since that time, we have now implemented an integrated public health information system that has moved from 36 different repositories of information spread across the province to a single province-wide integrated data system that now functions as a surveillance system. It's a key component in enabling the health units and the ministry to conduct active disease monitoring and for infectious disease outbreaks and infectious disease surveillance. It relies on standardized data collection and reporting requirements for case identification, and management, contact identification, and outbreak management, and allows for consistent reporting. So where we were was in a very antiquated, neglected system that largely had to rely on paper-based mechanisms to collect information during the height of an outbreak that had captured public attention like no other. Where we are now is an entirely different place with an application that enables province-wide access and integrated data retrieval for infectious disease surveillance. Next on the horizon are some of the challenges with immunization information. And I remember reading in the media clips that get circulated at the provincial level that immunization data has been a recent issue here in Waterloo, where a large number of students were suspended from school because their immunization record was not up to date. So I want to stop there for a second and ask you to just consider some of the issues that are implicit in this one. Largely, we have a highly immunized population. Most of the people who live in this region would have received the necessary immunizations at appropriate time intervals during their lives. What we have is an information management challenge. The immunizations are administered in a physician's office. They're written in a paper chart. That paper chart is in a file cabinet in that physician's office. Sometimes the parent or the patient is provided with a little card that says you received this particular information or immunization at on this particular date, but that's not always true. And then we expect public health agencies on the other side to have a record of that person's immunization with no inputs to this process other than what that parent may be able to provide us. So how accurate is that information that that parent might provide for that child? Is it indeed validated on the basis of what that physician actually administered on that particular day? Is it pure recall? Oh yes, I think I got that vaccine 3 weeks ago or 6 months ago or 3 years ago. Those are some of the challenges that we have. So as you can see, it's not necessarily a population that isn't being immunized. It's a population for whom the data about the immunization isn't making its way to all of the parties that need to hear about it in order to allow for effective action. Now, you might be asking yourself, why would public health need to know that those children are indeed immunized? And that's to ensure that we can effectively protect those school children in that school were one of those particular conditions to be introduced in that school. So let's imagine a case where, as happened recently, a case of measles was imported into Canada. And that particular child who develops measles attends your children's school. Well, there will be children at risk in that particular school, either because they have medical exemptions for immunization, or they may have conscientiously objected to immunization, but they are at risk. And if they get infected, they have the potential to spread to others in their circle of contacts. So it's a huge public health issue to understand the immunization patterns within a community as manifested primarily at a school level. And yet we face this huge challenge. We can't get this information, and most of the time we get this information from parents as opposed to the healthcare providers because there's no linkage between the healthcare provider and the public health system. So we're hoping to transform that by introducing an immunization information management through an integrated system that would include an immunization registry and the mechanisms for vaccine ordering and distribution. Again, one of the things you may never have thought about is that while you pay for your drugs, you've never had to pay for a vaccine unless you were traveling to a foreign country, because we provide, through the public health system, those vaccines to your doctor to administer to you. And what we need to do is move from a very antiquated, arcane system, as I've described, to something that's near to real time, something where information can be captured at each point in the process. And so the concepts that are being explored here are novel concepts. I mean, can we use the barcodes that are on the vaccine boxes to actually automate the type of data entry that would otherwise have to be manually done within a physician's office? Those are the types of questions that have to be considered. Clearly, Walmart has solved this problem. The health system has not solved this problem. There's a pan-Canadian public health surveillance initiative right now, and that illustrates one of the other issues that I tried to raise in my introduction, and that is that public health issues do change and that you do need effective surveillance mechanisms. And more to the point, those surveillance mechanisms, the ability to really detect new conditions and particularly new threats to the health of the public, don't just exist in Ontario, but really exist across all of Canada. And so there has to be greater interoperability across surveillance initiatives across the country. So the pan-Canadian surveillance solution includes efforts to try to address communicable disease and outbreak management, immunizations as I've described, establish the data standards for data warehousing and the alerts and notification schedules of the types that I described to get that urgent, important information about what you need to do in order to protect a particular community against an outbreak, get that type of information out as quickly as possible. And again, we're dealing with timelines for a interprovincial, federal, provincial, territorial initiative that largely stretch over the next 4 to 5 years and, again, allow us to start to upgrade our systems in public health. The electronic health record has been no doubt raised at previous seminars in this series, and that is something that, again, I'm not an expert on. But I do want to illustrate that, again, connections with an electronic record of health-related information on individuals is an important issue for public health as well, even though we work at a community level. And the example, again, is the immunization data. We are providers of immunization. So for those of you who might have had a child go through grade 7, you will have no doubt seen a form that comes home that talks about hepatitis B immunization that happens in a school setting through public health nurses. So we're providers of immunization, and the physician, your family physician, should actually know about that. And so there needs to be a mechanism of conveying that information back and forth. Equally, for the reasons I mentioned earlier, we need to know about those immunizations that are happening in other settings, including the physician office, the long-term care facility, et cetera. And so that aspect, that integrating aspect of an electronic health record holds some promise to solve that particular challenge that I'm describing. And the last of the applications that is currently under development is that of a public health inspection information system. And so again, if you go back to the introductory concepts that I put forward, the concepts of water system, the concepts of restaurants needing to be inspected, the concept of West Nile virus surveillance, these all occur around addresses, if you like. They are place-based. There are activities that are taking place at a particular location that result in a particular outcome. Very different than the types of information products and conceptual architecture you use when you're talking about person-based systems. And so the distinction between the last slide and this one is really to drive at the fact that public health action largely also has to accommodate the type of place-based information that is reflected in inspection information products as examples. And a particular example of that is the small public drinking water system, which, again, based on my comments at the beginning, won't surprise you to know that there are thousands and thousands of small drinking water systems spread across this province that require that type of inspection or mechanism to design that data collection. So what I've tried to paint for you is an understanding of what the public health system does in very general and very specific terms in a very few areas, not covering the total waterfront, but just a few areas. to give you an understanding of the work that we do that is largely invisible, to try to ensure that our communities are protected, that the health of the people in our communities is protected, and that we promote the best conditions possible to optimize our health. That the paradigms are different than clinical medicine, that we're not talking exclusively about person-based systems, about electronic health records, and integrating everything at that level, but that what we require are very different mechanisms to ensure that we can do our jobs to protect and convey the information that is necessary in order to achieve the goals that I've outlined. So I'll stop there and take any questions you might have.
Oh, very interesting. Questions, comments from anyone? I'll get the microphone to you, or Don will, so give you a chance to. I got a couple of them. You had, last slide, you had something called cold chain. What's that?
A vaccine is, most of the vaccines that are in use right now are only effective if they are maintained between 2 and 8 degrees Celsius. So it's one thing to know that a physician's office has a particular supply of vaccine. It's another thing to know that that supply of vaccine has been maintained at the appropriate temperature from the time it left the factory where it was manufactured right through to the time at which it is now taken out of that fridge for administration to that particular patient. You can no doubt imagine that there are fluctuations in temperature in that fridge as it's opened and closed a dozen times during the course of that day. And so the concepts of maintaining cold chain is an integral component of an effective vaccine program, because unless you can ensure that the cold chain has happened or has been maintained, you can't in fact ensure that that product that's being administered is actually going to work.
So it's sort of like the chain of evidence in CSI. So we've got another analogy here. Another quick question is, given that public health works closely with children, and given that the medical system also works with children, I mean, how do you build that bridge more than through a single database? I mean, what is the communication mechanism? So one of the things we've explored before is the challenge of getting physicians integrated into the e-health environment. It's been largely a failure so far in Ontario. And I mean, how is that going to be built, that bridge between the clinics and offices and the public health environment?
Well, those are largely issues that go well beyond the public health environment and more into the physician environment, and I'm not as expert in that particular area. So all I can say is that other provinces seem to have addressed this particular challenge, that there have been successes reported in the abilities to move beyond the paper-based systems that are, I think, familiar to most of us in terms of the provision of clinical medicine in physicians' offices currently, that they have used a variety of enablers to get to that particular point, none of which I'm able to speak expertly on, but that the concepts of electronic literacy, which are really at the bottom of this, I think are at the heart of your question. It amazes me when we consider medical education that we take medical students who basically walk around in hospitals with their portable technology and have everything at their disposal in the context of whatever, the Palm Pilots or related types of products that they may be using, any of the products that they utilize in that context. And then we put them, they graduate and we put them into an environment that is predominantly paper-based, and they quickly abandon the types of technological supports that they have used up until that point. And I think we've got to bridge that particular divide.
So one aspect is essentially computer literacy in the physician community. What about the other side, about the public health system reaching into the community environment, sort of build a bridge from both sides? What goes on there where you more tightly integrate public health with the physician community? Is there an activity like that? Or?
I think there are emerging efforts. I mean, the concept of the eHealth Ontario portal as an example of that is really at the heart of that issue. I mean, building on the backbone of a single portal environment, the opportunity for the broader health sector, physicians, nurses, everyone else, to really access the type of information that public health has is really at the heart of that particular vision. I mean, we've got to remember that public health is a minute component of the healthcare system in this province. We don't have the ability of having one of my staff in every physician's office in order to build that particular link. We don't have those mechanisms. So our actions are largely at a community level, looking for the best ways to influence and work with the health provider community.
Interesting. Question? One in the back.
I was just wondering how the provincial effort is going to be linking with some of the federal programs like the InfoWay or FinFly's kiosk.
Thank you. The question for those who may not have heard it was how the provincial efforts link with the federal efforts in InfoWay and related activities. And the answer is that they're largely heavily integrated. I mean, one of the things that colleagues that work at the ministry work extensively on are all of the federal, provincial, territorial committees that largely oversee some of those national initiatives. So the pan-Canadian surveillance solution that I described is largely an InfoWay strategy. The efforts to migrate from where we are, both in Ontario and across other provinces, is largely being considered in common planning for us, so that we can move from where we are with many different systems doing many different things across many different jurisdictions to a more consistent and common environment across the country.
Yeah, I was just wondering because will it be that the public health units or public health inspectors or physicians are going to 4 different sites to differentiate the needs somehow, or
One hopes not. Time will tell.
Make sure you have a microphone when you're making comments or asking questions. Bill, you have one from the web?
Yep, from the web, Mayor asks, can you describe what standards in architecture and transition support under PH eHealth Framework slide 34 mean?
The concepts of standards in architecture is an interesting one. When you take any type of system that has largely existed on a decentralized basis and try to impose a single information platform, single solution onto that, you're going to face certain challenges. I mean, when I describe the system as being 36 health units, and even in the areas of communicable disease control, those 36 health units maintain their own system prior to the introduction of the system that I described to you. So in an effort to move from decentralized to a more integrated solution, you have to establish certain standards and establish certain architecture in order to guide that particular process. You also have to manage the process of change. As we've, I think, all experienced when you're introducing new technology of any type, it's one thing to design the technology, it's an entirely different thing to ensure that people are appropriately prepared for it, that work processes are considered, that the issues of supporting technologies and supporting environments are considered. And so that transition support is an incredibly important component of any type of technology initiative. And so the latter two components were largely reflections of those concepts.
Just there's the follow-up question. It's just what are some example activities in these areas? Maybe go into a little more depth, I think.
I think I've tried to cover that off already, so I don't know if I have that much more that I can share.
Okay. Excuse me one second. Alex?
My question, actually, I've got a comment and a question. I was at a boot camp a month and a half ago or so, and one of the InfoWay employees made a comment when we were on a muffin and coffee break that we are one avian flu outbreak away from having all the EHR we need. That being something that would motivate us all to move quickly, where we've been moving so glacially up until this point. Well, one of the things that I found interesting was you said that there were the 36 regions, the public health regions. Now, we've recently introduced the 14 LINs in the province, and how do those overlap with each other? And in terms of governance, and especially in an immunization or an avian flu outbreak where you'd have to coordinate so readily with hospitals and with physicians, is there a good overlap there or a poor overlap there, and would some rationalization be useful?
Well, there are many questions implicit in what you've described, so I'll try to tackle them one by one. The first is what is the degree of concordance, I'm rephrasing your question, but what is the degree of concordance between the public health system currently and the newly introduced LIN environments? So there are 14 LINs across the province, and in some areas of the province there is a relatively good many-to-one relationship, that is several health units all being located within the boundary of one particular LIN. In other areas of the province, that degree of concordance is less uniform, particularly in the area around Toronto, because in the LIN geography, the geography is largely based on issues of catchment areas around acute services predominantly. And around Toronto, there are many different areas that come into the area of Toronto itself. So Toronto is shared by 5 LINs, is the short version of that. Toronto has 1 health unit. So you can immediately see the disconnect between the LIN relationship and the health unit relationship in that context. One of the projects that I have been responsible for overseeing is something called a capacity review, and one of the issues that it looked at was the issue of what should the infrastructure for public health be across the province, and what should it be in the context of LINs as one particular factor that was considered. I think it's important to recognize that public health works at a community level, and community levels aren't defined by the boundaries that LINs were drawn by. Public health interactions are as important with your local school board as they are with a LIN or with a hospital. And so there's a whole range of community dynamics that are necessary that need to be considered in designing an appropriate public health infrastructure.
Back here. You have a question?
Well, I was back to this gentleman's reference to examples of standards of architecture and managing process of change. Wondered if you wanted to talk a little bit about records custodianship. That's maybe an interesting area.
Who owns the record is, I guess, the short form of the question, and that is an interesting challenge. I think you've got to appreciate that I come at the issues of e-health as a provider, not as someone who is an expert on the technology side. So I can't give you a legal answer as to, where the custodianship or the custody and the control of a record resides when it's been entered, in Thunder Bay by a member of a public health agency there, but actually physically resides in the electrons that are present at an SSHA data center that may exist on an arm's length basis from the Ministry of Health that is the custodian of that system. I don't have the answer to that particular question. What I can say is that certainly from a program perspective, it is incredibly important that we move beyond the issue of who owns the data to who needs to access the data, and can we establish the appropriate controls so that only the people who should be accessing that data can access it. And that's the legal framework that I'm more familiar with in the context of the Personal Health Information Protection Act.
Question here.
Hi. I'm wondering if there's anywhere in Canada or North America that you look to as having better best practices or best practices that you'd like to adopt in Ontario, particularly in Canada, given the regionalization effort we're having in Ontario and the 10-year-old regionalization effort they've had in BC and Alberta. Does that equate to better practices from a public health perspective as well?
I think that certainly it is always the case that there are lessons to be learned from other jurisdictions, and sometimes they occur at a macro level, and sometimes they occur at a very, very specific or micro level. But what is important for the audience to appreciate in this is that the public health systems across Canada tend to be very different. You've mentioned one aspect of that difference. Some are part of a regional health authority. In Ontario, we don't have regional health authorities. We have the evolution of LINs as a planning and funding body, but not as a regional health authority. We have other major programmatic differences. In some provinces, I'll take the example of food inspection or restaurant inspection. In some provinces, that's a responsibility of public health agencies. In some, it's responsibility of municipalities. In others, it's the responsibility of the component of the provincial ministry that deals with food, food and agricultural issues. So there are major variances between provinces in what they constitute as a public health system. So there is less potential for shared solutions in those things that are different. There's more potential for shared solutions in those things that are very similar. Surveillance, risk assessment, infectious disease control tend to be the things that are almost always common across the country. So are there jurisdictions that are looked to in that regard? I would say that largely the systems that we have adopted arose from the experiences of other provinces. So the IFAS system that was the subject of one of the slides arose from BC as an example. So yes, that process is always occurring.
Okay, another question from the web. Is there any demand or backlog for applied health informaticians in your projects? What skills are you looking for?
I think on a macro level, I would say, on a system level, I would say that there continues to be a major challenge in public health, possibly greater than in other areas of the health sector, in that experts in health informatics have not yet been integrated into the workforce. And so there are real challenges that we face in this area because many of the agencies that I've mentioned would not have a health information specialist, for lack of a better word, on staff. So is there the opportunity as the future unfolds to really start to consider that? Certainly. Am I aware of any immediate openings? No, not particularly, but that I don't think was at the heart of the question. I think the concept here is that in order to move a public health agenda forward, informatics is going to be critically important, especially if the rest of the healthcare system is also moving along that same path. And the skills that are necessary in understanding the relationship between data, its transformation to information in a way that can be utilized effectively by the frontline staff, by decision makers, by managers, are really at the heart of what is necessary over the next 5 to 10 years.
Those of you who aren't aware, there's an area of expertise called public health informatics, in fact, which is growing quite astoundingly in the States right now. So there are people who are specializing in this area, and there's a really excellent book in the Springer Verlag series by Bill Yasnoff on public health informatics. And if you're interested, we can put together some material for you. The other thing I wanted to mention is, I've forgotten the student's last name, but Rick from Management Sciences, one of my graduate students, did a review of the public health systems across Canada. And if anyone wants to see the divergences that exist and the similarities, I'd be happy to share that with them. And I think you'd find it very informative in terms of what's common and what's different across the country. Might be of some use. Let me make sure everybody else's questions. I have one. This is kind of going off the other side, and I understand public health itself has certain authority in the regional and local and so on situations. I think you can shut down restaurants if they don't meet your inspection requirements. What are the other authorities in public health? We saw a little bit of that about SARS, but to what extent do they exist, maybe from the bigger ones to the smaller ones, if you can do that?
Well, I would say that first off, public health tries to, wherever possible, exercise its mandate through the mechanisms of education, providing information, trying to influence people's choices in a way that maximally addresses the health protection and health promotion challenges. But there are rare circumstances where the use of public health powers becomes necessary, and certainly you've highlighted on several of them. In Ontario, there really are just two basic powers. One is a set of powers that looks at health hazards and empowers a public health inspector or a medical officer of health to take certain actions to address that health hazard. And those actions can be many, and you've cited one example, which is if there was a persistent threat to health on the basis of the conditions of a particular premises, you might be able to close that particular premises. The other set of public health powers are largely aimed at on a personal level, and they're largely related to communicable disease. And so where the actions of an individual may pose a direct threat to others, public health can issue orders to constrain those actions. And so largely speaking, they're environmental and on a personal basis related to communicable disease control.
Now, related to that, I think public health also has a responsibility or authority in the area of air quality. Is that true or not? Am I wrong about that one?
That one would be a stretch. So I would say that's not a direct responsibility.
Okay, so that's not a direct. So if you're in a situation where there's an emission of a poisonous substance, presumably that's the case, but not in terms of global air quality.
Correct.
Okay, that's the differential there.
Yeah.
In that situation, I presume you have powers of evacuation and that kind of thing. I mean,
there are actions that, again, can be taken in the context of those health hazard powers, but usually when you're dealing with that type of event, you largely have invoked municipal emergency response powers. And so you will have, you'll have heard the term, the mayor declared a state of emergency, and therefore the following actions were taken. Well, usually that's in the context of a community emergency at that time.
Okay.
Question. Apropos of our conversations earlier, in this area, the public health unit in some sense is owned by the region. I don't mean that in the actual sense. And they get all their IT services from the region, which is a good news and bad news scenario. It means they have a larger IT department. It also means they're competing with a lot of other departments. And I'm just wondering what the picture is like across the province. Because just looking at your map, I have a feeling it's all over the place, but I don't know.
Yeah, well, I think your question largely surfaces the issue of variability again, and I think that variability with respect to the technology supports broadly defined within those agencies is quite diverse. The best example I can give you is that those municipalities, those health units that are directly aligned with a regional municipality or a single-tier municipality like the City of Toronto or the City of Hamilton or the City of Ottawa do have direct access to the technology departments in those areas. Yes, they suffer from the competing demands issues related to those particular environments. On the other side, the other, roughly speaking, 26 health units in the province are independent autonomous corporations. If they need something, they have to contract for it or they have to staff it. And they tend to have very limited staff supports in the areas of technology. The organization that I served as the MOH and CEO for basically had 3 people largely responsible for everything in the technology domain, from limited database development right through to professional development of staff on office software.
George, I want to thank you very much for a really informative presentation.
Thank you. Again, I want to thank the sponsors for the seminar series as well as the Institute for the invitation. It was very enjoyable to
We have
come and
2 other very brief things. One is we do the draw for the BlackBerry, and is Doug going to help me with that? Is that the story? He's a trusted person here. I'm not. So I hold up higher than him, which is harder for a shorty like me. Oh, you want to do it? Okay, good. Public health will make the choice today. And the name of the lucky person is Deborah Hagman. Deborah in the audience here or online?
Not online.
Not online. Okay, next one.
We drive when we win.
You got, yeah. This is great. You get many chances this way. Okay, the next one is Lori Donnell. Oh, Lori, you missed it today. I know that's tragic. That's 2 unlucky people. Keep doing this. Eventually, we will get one. Poor Lori. And Joel Dubin. Oh, close but no cigar. Next one. This is terrible. We have to draw the entire box here. Okay, next one is Jenny Brown. Yay! Jenny's the winner of a BlackBerry.